So I think we can go ahead and get started. Marianne, as long as you are ready. Um, Thank you everyone for joining us today. I think a few people are going to kind of hop on as we keep going here. But first things first, I'm going to start or just launch a poll, just so we can learn a little bit more about everyone who's joined us today. And yeah, so the questions are, what is your profession, and how often do you recommend standing technology for individuals other than pediatrics or those with a spinal cord injury? So go ahead and answer those questions. Again, thank you for joining us at today's webinar. We're happy that you're here. The course slides are available through the link that I will put in the chat, or on Ultimate Medical's website under the webinars tab on our education page. It's ultimatemedical.com/education, ALTIMATE medical.com/education. Like I said, I'll post the link one more time before Marianne starts her presentation, and the link that I'll post will download the slides automatically. If you have questions during the presentation, please put them in the Q&A or chat section. I'll be monitoring both, and we'll have time to answer those questions at the end. To obtain your CEU credit for this course, you must complete the survey at the end of the webinar. The survey should automatically populate after you exit the webinar. If it doesn't automatically populate in your browser, don't worry. The link will be available to you in a follow-up email that you will receive in approximately 24 hours, and you'll be able to access your survey that way. With that, thank you for joining us, and I hope you enjoy the webinar, and I will turn it over to Marianne.
Thanks, Samantha. Hi, everybody, and welcome to Benefits of Standing for Adults with Neuromotor Disorders. My name is Marianne Girardi. I'm the Clinical Education Specialist here at Ultimate Medical. We are the manufacturers of Easy Stand and Zinc standers and Activate bath safety equipment. I have been a physical therapist for the past 41 years. I've pretty much worked in every setting there is, both acute care, home care, group homes, acute rehab. I ran a seating clinic for a while. For pediatrics, I worked in both private schools, public schools, daycares, day programs, institutions. One time I was a dealer, and I was also a reviewer for Mass Health, where I reviewed all of the complex rehab technology prior authorizations for the state of Massachusetts. So I bring a little bit of experience to this. As I said, I am a full-time employee of Ultimate Medical. Today's learning objectives are going to be list a minimum of 3 neuromotor disorders that benefit from the use of standing technology. Discuss the evidence supporting the use of standing technology for adults with neuromotor disorders, and describe how standing technology can be integrated into an individual's plan of care. For the purpose of today's discussion, we're going to use a very global definition of neuromotor disorders. It's an injury caused by damage to the central nervous system. It can be developmental or acquired through injury or illness, and it affects muscle tone, movement, posture, gross and fine motor skills. So basically, we're talking very globally about any injury to the central injury and or damage. It could be congenital damage to the central nervous system that causes movement disorders. And then specifically, we're going to be talking more about those individuals with neuromotor disorders who are unable to stand by themselves. I think when we think of standing in our society, and actually society as a whole, puts a very high value on the ability to be standing and the standing position. Standing upright symbolizes moral rectitude, vigor, dignity, and autonomy. Those are all really strong emotional words describing what standing means to people and the ability to stand. When you think about your body language, and when you we all went to body language school at some point or another, and the position of power is the position of standing. You want to be above the person you're talking to, so you have the upper hand. You are taller, you are stronger. And when you think of somebody that you don't think well of, you say you look down upon them. So throughout our society, the value of standing is very high, and we use the term, we look down upon, and you view people who are seated or unable to be in the standing position, or in any case are just not in the standing position, if you're in negotiations and stuff, as having a lesser value and being more marginalized in society. When we talk about the benefits of standing for the people who are using it, there was a survey done with people ages 2 to 86 who use a standing device and have been using it for more than a year, and asked what do they feel the benefits of their standing technology is for them. 87% has said they had an improved sense of well-being. They had a sense of normalcy and enjoyment. They had increased participation in activities. And those of you who have heard me talk before, I always wonder, is the increased participation because they are in a vertical position, in a position easier to access things physically? Or is it because they feel better about themselves? They have a sense of freedom. They have a sense of well-being and being normal, and therefore are more willing and want to participate. We've all heard and read about people with depression and mental illness, but people who are not feeling well about themselves tend not to want to participate in activities. They don't find the same enjoyment. So by increasing the feelings of well-being, are we increasing the person's ability and or opportunities to participate? Food for thought. And 25% reported improved sleep. I think that's so important, and we've seen studies, especially in the recent years, that you need to have, I think it's 7 to 8 hours of sleep. A lot of adults don't get it, especially if you're working full time. But we need to have, our body needs that amount of sleep to be able to renew itself, to rest, and to reset the clocks. So if you can get improved sleep just by using a stander, I think it's worth it. Problem with all these benefits is they're not medically necessary. We live in a payer-driven system, and our payers only want to pay for things that are considered medical necessity. Part of the definition of medical necessity is that the piece of equipment or the service being requested is that it's going to make a difference, sorry, to improvement, take the place of a lost part. It needs to make a change that works with the impairments that they have. So when we're trying to get standards and anything else approved through a third-party payer, we need to demonstrate that there is medical necessity to it. So the medical benefits of standing are bone mineral density, spasticity, range of motion, motor skills, respiration, bowel and bladder function. When you're up and standing in a standing technology, it provides mechanical loading to your bones and muscles. It provides symmetrical alignment. We need to be maintained, or at least get into symmetrically aligned, because the body is designed to work in symmetry. When we move out of into asymmetrical alignment, we stress parts of the body because that's not how it's designed to work. It provides a prolonged stretch. It stimulates your sensory systems, including proprioception and touch. It also stimulates the vestibular system. Moving from the supine or the seated position up into standing stimulates all of these systems, and it also initiates postural reactions. We hear a lot of talk about osteoporosis and bone mineral density in people who are not able to weight bear. Disuse osteoporosis is the bone loss due to skeletal unloading. We are not putting stresses on our skeletal system because we're not weight bearing in gravity. when we put stresses on our skeletal system is going to react and make sure that our skeletal system is able to withstand these stresses. One of the things that happen is in the osteoblasts in the bone are mechanical receptors, and the mechanical receptors in the osteoblasts regulate the release of the protein sclerostin. Why this is important in osteoporosis is because the whole purpose of that protein is to inhibit bone growth. It is when the levels of sclerostin are high, bone growth is harder to accomplish. So by weight bearing, you stimulate the mechanical receptors to decrease the levels of sclerostin in the bone to enable a better environment to facilitate bone growth. In osteoporosis, we have high bone reabsorption and low bone formation. We have found that weight bearing decreases reabsorption. So basically, what's happening with your bone mineral density is from the up till the age of 25 or 30, you're gaining bone mineral density. You're putting it into the savings account. You're putting it in, you're making your deposits so that when you hit 40, everyone starts to reabsorb their bone mineral density. They start to lose it. So you're building up your bank account so that when you make those withdrawals after the age of 40, you don't decrease to a level where you're at a high risk of fractures. And standing can help slow down those withdrawals. When we talk about bone mineral density and fractures, what we need to remember is that once you get below 1 gram per centimeter squared of bone mineral density, you are at higher risk for fractures. So no matter what we do, we need to keep trying to maintain it above that 1 gram per centimeter squared. In the United States, there's 1.5 million osteoporosis-related fractures each year. This is the whole population, not just the population with a disability. But within the disability community, spinal cord injuries have 100 times the fracture rate by the time they're 50 years old. Strokes patients have 7 times the fracture rate. MS, 20 to 40%, an increased fracture rate because of their disability, because of their non-weight bearing, and in some cases, the medications that they're taking. They lose bone mineral density faster than the typical population. And the contributing factors are immobility, mechanical unloading. So you're not weight bearing, you're not loading your bones to produce more bone mineral density or to slow down the reabsorption, and the time since injury. The longer it's been since you were injured and you started the not mechanically loading your joints, the more withdrawals have been made from that savings account. So the further out you're from that injury, the lesser bone mineral density you have and the higher risk of fractures. We know about losing bone mineral density in disability is that the greatest percentage or a quicker percent amount is lost within the first few months, sometimes the first few weeks. With spinal cord, this was started 1 to 4 weeks post-injury. And this study divided the groups into 3 sessions, or three groups: immobilization, standing, and walking. At the end of the study, they found that the immobilization group lost 6 to 9 to 9.4% of their bone mineral density. The standing and walking had only a moderate loss or a moderate increase in bone mineral density. This is important because the standing has slowed down the reabsorption, which we normally have. Remember, when you have disability and injury, the first few weeks and the first few months, you're going to lose the greatest amount. With people with spinal cord injury, by the time they're 2 years post, they have lost 50 to 70% of their original bone mass they had at the date of injury. It happens quickly and it continues to happen. In this study, they studied a group, they started 8 to 12 weeks post-SCI. During the first year, They had two groups, standing and non-standing. During the first year, the standing group lost 19.62% of their bone mineral density. The non-standing group lost 24%. I know it doesn't sound, it's less than 5% difference in the amount of bone mineral density that both groups lost. But what's important is that the standing group stayed above the 1 gram per centimeter squared at the 2-year mark. Remember, I told you at 2 years, spinal cord injury patients can lose up to 70% of the bone mineral density they had at the start when they were first injured. They were able to maintain it above that critical value of 1 gram per centimeter squared. The non-standing group went below that critical value and were at increased risk for injury. I know anyone who works with spinal cord has had this happen or has heard this happen. I was waiting for somebody in a seating clinic appointment, and I'd known this person for at least 5-6 years at that point, and he was never late. He was never late. And the vendor's there with me, and we're waiting, and my cell phone rang. And I picked up my cell phone, and I'm like, Joe, where are you? We're waiting. You're already 15 minutes late. He's like, I'm in the ER. I'm like, oh God. He was putting his shoes on to come to the appointment, picked his leg up, crossed his leg over to put his shoe on. He sustained a spiral fracture of his femur because of his decreased bone mineral density. He was injured at 16. He was now in his 30s. He never had a stander and never did standing. But just the simple action of rotating his leg up to put his shoe on was enough to do a fracture of his femur that required surgical repair. And this happens frequently with people with osteoporosis and low bone mineral density. It's the low trauma fractures that we're worried about. We're not so much worried about if the foot gets caught in the caster and you do a stand pivot. That's a pretty high trauma. But if the foot's flat in the ground, you do a stand pivot and you get a fracture. That's a really low trauma fracture, and you have to be worried about the bone mineral density of that person. It occurs in stroke. It occurs in anybody who becomes non-weight bearing and immobile. Again, it happens in the first few months, the majority of the loss. When the non-ambulatory people, they found that they had a 10% paretic loss on the paretic side. I apologize, I'm getting over the flu and I'm hoping my voice holds out. And a 5% loss on the non-paretic side. What's the difference? That they're doing some weight bearing on the paretic side. And the ambulatory, they only had a 3% loss on the paretic side. You need to have weight bearing to maintain your bone mineral density. In strokes, they find that the percentage of weight bearing they have on the paretic leg also is indicative of the speed of reduction in bone mineral density. Those that aren't bearing a lot of weight will lose more bone mineral density quicker in the beginning. Think of when you get somebody with a stroke up. They stand up and they stand up on the one side. They're not secure in their posture and standing on both legs because they're not trusting that leg. It feels different. They don't know that it's there most of the time. Sometimes they do. If you start using a stander, we can provide them the ability to weight bear equally on both legs in a safe environment. We're going to provide them the structure to get up and be safe and not worry about falling over. We're going to provide them the support to shift them over onto that leg, and that leg's not going to give out on it because we've got it supported, and they can relearn how to stand and balance. In a lot of neuromotor disorders, spasticity is a huge component, and in therapy, it comes into play a lot. 38% of our stroke survivors experience spasticity within 1 year after the first stroke. 84% of people with muscular sclerosis have spasticity. 34% of those say that their spasticity affects their ability to live their daily life. 62% of spinal cord and 82.9% of cerebral palsy have spasticity that affects their life. I include this slide in all of my talks because I think it brings home a point about weight bearing. One session, 30 minutes, a little bit of dorsiflexion at the ankle with somebody post-stroke, acute stroke. After 30 minutes of standing and weight bearing, the modified Ashworth scale, or the scale that's used to measure spasticity, dropped 1 full point. At 45 minutes, it dropped even more. Think of what this could mean if you're working with somebody and spasticity is one of your biggest obstacles in therapy, or it's really impeding your ability to do things in therapy or in their life. But if you can get them standing in a standing frame a half hour before they come to your session, you can have a reduction in spasticity and have maybe a better opportunity to get more volitional movement, or at least to work towards more volitional movement, because you're not fighting the spasticity when you're doing your therapy. This study was 9 paraplegics, 8 sessions, 4 consecutive days, 30 minutes of stretch or 30 minutes of weight load. The stretching was done via bracing and maximum dorsiflexion while they were laying supine. The weight load was done in standing 85 degrees, so 5 off perpendicular, with 15 degrees of dorsiflexion or 15 degrees of plantar flexion. Why I like this study and why I find it important is most of the studies that are done working on spasticity, for some reason, they're all looking at the plantar flexors. But what they usually do is they always put the person into dorsiflexion, so they get that maximum stretch of the gastroc soleus and the plantar flexors to decrease the tone. After the standing program, after the 4 consecutive days, they found the spasticity reduction was 32% in those that stood in dorsiflexion, but 26% of those who stood in plantar flexion. What this is telling me is that it's not so much the muscle stretch that's causing the reduction in plantar flex and spasticity, but it's the weight bearing, because you don't have the maximum flex or stretch in plantar flexion, but you're still getting a reduction in tone. And stretching alone in supine was only a 17% reduction. So getting people up weight bearing in alignment, you can get an efficient reduction in spasticity in 30 minutes. When we talk about spasticity and range of motion, they go hand in hand. For years, we all thought it's the spasticity that causes deformities. It's the spasticity that causes the contractures. Well, in 1976, 2 doctors in Scotland discovered that it's not the spasticity. The spasticity is the cause of the joint going into the shorter range of motion. But that's not what's causing the contraction. What's causing the contractures is they're not moving out of that shortened joint. They're not able to change their position, so they're staying in the shortened range of motion, and the body adapts. That's what our body does, or else we wouldn't be living now. We've been adapting for eons. When you don't move through your full range of motion, the muscles are going to shorten because they're going to maintain the mechanical advantage for the range of motion that you use daily. You don't need the extra range of motion because you're not using it. So to work on range of motion, you need to maintain them out of the contracture or at maximum length stretch for a prolonged stretch for a longer period of time. And we saw from the study before that if you do that stretch in standing, you're going to get the effects of weight bearing on the tone too. This study is not statistically significant. And we know that the levels of evidence for standing and the use of standing technology aren't extremely high. They're not very high, but there is evidence. It's not a lot of statistically significant changes that are found, mostly because the sample sizes are so small. So to get the change, it would have to be greater. But this had 20 SCI patients, 12 weeks of standing, 30 minutes of standing 3 days a week, which is a little bit less than what I've seen recommended of 5 days a week. They had a mean increase of 4 degrees in ankle range of motion. I know that doesn't seem a lot, and sometimes it's considered within standard of error, but you need to have at least a neutral foot or a little bit of dorsiflexion to enable you to get a good alignment. And if you're working towards ambulation, anything less throws off the kinetic chain up the leg and then up the body. So if you can get that 4 degrees for that one person who only needs 2 degrees, you're doing okay. What I also like about this is that it showed that there was a very minuscule, very, very, very tiny increase in bone mineral density, but there was an increase. Remember, I told you that you're going to consistently lose, and if you can slow down the reabsorption, you'll be able to maintain yourself above that 1.0 gram per centimeter squared, where the severe increase in risk of fracture occurs. So any gain is okay. We can use standing for multiple sclerosis patients. It's not as popular here in the United States. It's very popular over in Europe. So we had 6 adults with secondary progressive MS standing 30 minutes a day or a daily exercise program. Then they did a crossover. So the standing group did the exercise group did the standing. After 3 weeks, there was significant improvement in hip and ankle range of motion in the standing phase. We've seen these types of studies with all types of population. This one doesn't look at the knee. A lot of the ones using that are done with cerebral palsy patient looks at the knees, and they had an 18-degree increase in knee extension. If we can get them out of that seated posture, move those joints to the full range of motion so that we're stretching and we're not allowing the muscle to shorten. People need to change their position frequently. And by changing your position frequently through your full range of motion, you can more easily maintain your range of motion. What they also saw in these people was a downward trend in the modified Ashworth scale. It wasn't big enough to be measured, but it was reduced. Think of just being able to stand. You're increasing range of motion, you're decreasing spasticity. I'm hoping you're increasing quality of life. In working with TBIs, muscle tone and spasticity, especially the plantar flexors, it seems to be pretty prevalent. I remember we would do sterile casting, we would do Botox, we would do everything, just trying to get the tone to a place and range of motion to a place where we could get these people to start working on the way back to their lives. 36 adults, ankle plantar flexion contractures. They had 2 groups, 6 weeks standing with E-stim and ankle splinting versus just 6 weeks of standing alone for 30 minutes. They found that standing alone had an average of 3 degrees more passive dorsiflexion. It's less costly intervention because you're not doing E-stim, you're not getting the ankle splint, you're not having to have extra people to get the system in. Once you get somebody up in a stander, they can go on their merry way as long as you've got them up there and they're safe, and you don't have to monitor. And you still get better range of motion than using the 2 together. People think of standing as a passive exercise if they're using a standing frame. Think of yourself when you're standing, you're never standing perfectly still. Even when you're in a standing frame, EMG studies have shown that once you get up into standing, the muscle activity in the anti-gravity muscles increases. They found in some cases that the metabolic level also increases, and it can get above what's considered light activity. So you think of people who are living a chair existence who aren't very active. And we're all talking about decreasing sedentary behavior, which is why we all have standing desks right now. That these people just getting up in a stander is considered light activity for them. It's considered exercise. This group of MS, 36 weeks, had a significant increase of 4.7 points in their motor scores. They were able to perform more independent motor function after they were participating in a stander. We gain strength and learn motor skills by practicing. If we don't have a safe environment to practice, our body will kind of hold back a little. If we don't have the ability to have a safe environment, we may not try it. But by getting people up and standing, they're able to practice in a safe environment and learn or relearn their motor skills. They also had a significant increase in dynamic sitting balance. So by standing in a static stander frame, you're increasing dynamic sitting balance. And dynamic sitting balance enables you to reach further out of your base support. It enables you to access your environment more, all by standing statically. Some people do not realize that all of your postures are connected. Lying, sitting, standing. And the skills and the strengths and gains you make in one transfer over to the other. Anecdotally, I've heard from multiple people who start standing programs who have had poor sitting balance or poor sitting posture, that once they started their programs, they had better sitting balance, they had better posture in sitting, and they were able to maintain seated alignment and posture longer because of the activities they're doing in standing. Sorry, so 50 stroke patients, 18 years of age, conventional therapy and 30 minutes of standing, 5 days a week for 2 weeks, or just conventional therapy. The group that had the conventional therapy and the standing, it's additional time to practice your skills and to learn new skills. They had significant changes in both the Berg balance test and the Rivermead motor assessment. So again, static standing adds to your therapy time because it's giving some of the same cues and input that we give during therapy with our hands through their system and the stander. And you can get balance increase. If you don't increase your balance, you're not going to be able to increase your motor skills. Lower extremity function alone, standing on a tilt table after a stroke, significantly increase lower extremity function from what is considered a passive activity. The body is working and learning, and we're stimulating all the senses to get up and go. This study was done with both ambulatory and non-ambulatory adult cerebral palsy individuals. They compared the groups that stood and had a regular standing program for a while, and those that had never stand or don't have a regular standing program. The standing group was able to achieve head control for greater than 30 seconds. And only the standing group was able to do a functional stand pivot transfer. What's important about a functional stand pivot transfer is its independence for the person. It's less stress on the caregiver. It's less stress on the health system because you don't need as many caregivers, but it's so important for the person to be able to control their own body movement. And we've seen that in multiple studies. I wished I had known about this when I was working acute rehab on the stroke floor. I've always asked, and I've actually found people who like to treat people with Pusher syndrome. I wish they were there when I was on the stroke floor. Pusher syndrome is, whenever I would see it come across my desk, I would be like, oh no. What Pusher syndrome is, for those of you who don't know, is that after a stroke, the patient's center of what they feel is centered and upright is way off to one side, and they will actively and forcibly push onto that side, which usually results, if you don't have anything, of them falling over. 58-year-old male. He had an 11 out of 17 pusher syndrome score on the Burke lateral propulsion scale. He got to rehab and they started standing him using a passive stander, got him up in therapy, was working until he was able to tolerate it for 30 minutes. We all know when you first go from a sedentary or supine or seated position into standing, you do sometimes have to deal with orthostatic hypotension and dizziness, and you can use compression stockings, abdominal binders, but we also know that the body has the ability to adjust and regulate itself to overcome the orthostasis. Does it always happen? No, but for a lot of the times it does. So they got him up to 30 minutes of standing safely in his stander, and then they took the standing out of therapy. It no longer took his direct therapy time. They moved it either to when he was watching TV, when he was doing speech therapy. We'll talk about why that's important. When he was just hanging out watching TV. So he ended up standing 30 minutes a day, 7 days a week. At the end of 24 days, he cleared pusher syndrome. Previous studies show that only 62% will resolve pusher syndrome after 6 weeks and 79% after 3 months. He did it in 24 days. Not only did he clear the pusher syndrome, he increased his functional independent measure. If somebody with similar circumstances, similar length of time in therapy would only have a 0.8 FIM score, which is the functional independent measure for those of you who don't know it. He had a 1.1. So he was able to progress in his functional skills more quickly by adding standing, first in therapy and then outside of therapy. People in a nursing home who a lot of times just sit. 13 SNF residents, ages 71 to 93 years old, 12 weeks of physical activity and standing. It didn't describe what the activity they did in standing was. It was just that they were up standing in a standing device. They increased their lower extremity strength and their FIM score, so the functional independent measure. They were able to do more for themselves. They also found that 60% of those who required assistance to stand prior to starting this program were able to move independently to sit to stand. That's important, again, for numerous reasons. One, because you don't need as much help and you don't need as much staff. Two, the person's feeling that they can emotionally, the feelings that they get, that they are able to stand on their own. Remember, in the beginning, we talked about the significant value standing has for people. So being able to move independently from sit to stand boosted their self-esteem. They had independent standing for a minute. A minute doesn't seem like a long time, but it can be a very long time, especially for me. The greatest time that you really want to have some independent standing, or the more helpful, is during toileting. That minute gives you time to get those pants up and down. It gives you time to do things. You're not having to support the person and everything else at the same time. When you're doing transfers, any type of transfer, if they can be up and stable in the standing position, then you can go along with the either stand step or whatever type of transfer you're doing. But the caregiver is not responsible for maintaining them in the upright posture for the whole time. They also were able to walk 15 minutes with a walker after completing 12 weeks of standing. An appropriate time for this slide to come up. Respiratory issues are the third leading cause of death in the United States for individuals with a disability. That's any disability, not just the neuromotors that we're talking about. People who aren't able to stand or have disabilities usually have decreased respiratory function. It's due to positioning, it's due to the neurological involvement, and it's due to muscle weakness. What they find that people with handicaps show mostly is they have a decreased vital capacity, they have a decreased tidal volume, and they have decreased forced expiratory volume. Just by standing alone, even this is both individuals with handicaps and individuals without handicaps. By moving from sit to stand, you have an increased vital capacity. You have an increased forced expiratory volume. Forced expiratory volume is important to cough. It's important to clear your lungs. It's important to talk. If you don't have a large expiratory volume or an increased expiratory volume, you have very soft and you can't really do it. You can't hear me. I use this example all the time. It was a gentleman in his 50s, C4 quadriplegic, 30 years post-injury, had not had a standing program, I think, since he was in acute rehab. He was referred to me to do standing. He wanted to get up to stand. So we did take very slow time getting him up to standing. I will be totally honest with you. I know it took more than a month because we were going very slow. When I first met him, to hear him speak, I had to stand next to him. After he had been in his standing program, and he stands daily, a couple times a day, I could hear him from across the room. When we ask people who have standers and use them regularly, 40% of them say they have improved breathing just by getting into standing. If you want to learn more about the respiratory benefits of standing, go to our website. There is a on-demand webinar that is specifically, it's about an hour and a half, and it's specifically on the anatomy of and physiology of breathing, directly related to spinal cord in that, but the exercise and the information you get can be shared into other disabilities. 15 adults who were intubated and mechanically vented, greater than 5 days. They started with passive tilting up to 70 degrees for 5 minutes. Just by moving them from either the seated or supine posture into upright, and it's 70 degrees, it's not even that far upright, it's not totally up. They had increased minute ventilation, increased tidal volume, and increased respiratory rate. They were able to maintain this during the whole time that they were standing and for a time afterwards. The study accredited that they were able to be weaned from their ventilation because of the respiratory practice exercise they got by using a stander. And it didn't have to be mechanically induced. Well, I guess standing is mechanically induced, but by bringing the body into upright, the body knows it needs to breathe deeper. It needs to breathe faster to maintain the oxygen levels that they need. Bowel function is probably one of the benefits of standing that we have the least amount of high level research on. There's actually not a whole lot of high level research or research in general. We find that people with disabilities, constipation is a huge issue. And it's not only because of their immobility and their sedentary lifestyle. I understand medications have a lot to play with it also, especially when you're into painkillers. But they find that people with stroke, 48% of the people with stroke deal with constipation, 41% of the traumatic brain injury, 50% of the MS, and 58% of the spinal cord injury patients. 39% of those with spinal cord injury say that their bowel care regime or their bowel issues, bowel functioning, limits their ability to participate in life. That's almost half the people who can't have full participation in life to the level that they want because of their bowel and their bowel care programs. So the one study showed that they stood 5 times a week. They had improved frequency of BMs and decreased bowel care time. When you look anecdotally, whether it's adults or pediatrics, caregivers and users alike, this is one of the top reasons why they use a stander, is to help them with their bowel functioning. Gravity assists the motility through the system. It aids in digestion, and it can, I won't say it will, but it can increase the frequency, and it definitely decreases the bowel care time. Bladder distension is the most common trigger for autonomic dysreflexia. We know that people who have neurogenic bladders have difficulty emptying them. People who sit for a long time have difficulty emptying their bladders. Just by moving sit to stand, your bladder pressure increases. It happens to handicapped people and people without disabilities. It's just a matter of the environment. Moving it up increases the pressure in the bladder. With an increased bladder pressure, you are able to empty your bladder easier. Those of us who've dealt with home health or any little old ladies, you stand them up for the first time of the day and you usually find out why. The bladder pressure increases and they don't have the tone to control it. You have an accident. When you can empty your bladder more easily, and empty it more fully, you decrease the environment for bacteria to grow, and you decrease the risk of UTIs, which are one of the leading infections for people with disabilities of all types. I know indwelling catheters brings up a whole new set of problems. They also found that spinal cord injured adults, in this case paraplegics, they were brought into standing and in a standing device, had an increased glomerular filtration rate. Their filtration rate for managing the waste fluids in their body and filtering the fluids in their body approached that of a normal person, of a person without a disability. 21% state they have improved emptying, again, decreasing the environment for bacteria and UTIs. We talked that once you hit 40, your body starts reabsorbing the bone mineral density. When it does this, it excretes calcium in the urine. They've done studies where they've shown the same people prior to standing and with a standing program have decreased amounts of calcium in the urine. Thereby, one would assume they are decreasing the reabsorption of bone and maintaining their bone mineral density. I know this is probably out of a lot of people's wheelhouse, but I think it's important to know that in ICUs, they've been using this for a while, the body using verticalization to combat disorders of consciousness. I mean, vegetative state, minimum vegetative state, decreased levels of consciousness. Think of it when your body is supine. When you go to lay down, your body starts to go into resting. The vestibular and the sensory stem going to the body are telling it to rest. What they're doing in the ICUs is they're getting these people and they're verticalizing them. They're standing them up. In most cases, they're using tilt tables, but I've talked to at least 2 hospitals that are using either easy stands or other standing frames for both children and adults for people who are newly injured. In this case, one was a spinal cord unit and the other one was a general pediatric hospital, 2 different parts of the country. They're getting these people up every day because what they're finding is that when you verticalize them, when you get the people up and you stimulate those senses, you get decreases in the Glasgow-Coma scale. You get decreases in the Richmond agitation sedation scale. The people are coming out of the decreased levels of consciousness faster when you're using verticalization. This is also true with stroke patients. They start 8 to 10 days post-injury, 8 to 13 training sessions. They had increased levels of consciousness after 4 to 6 sessions. Sometimes it takes people a long time to come out of the decreased level of consciousness once there's been that injury to the brain. By using verticalization and stimulating all the sensory areas that you do and the vestibular system, they're finding it will end and bring them into increased levels of consciousness just by using it. So we've talked about the medical benefits, but what do the people who use standing feel about the medical benefits? What do they think they get from them? Well, these are 2 studies. Again, one is just spinal cord and one is all users. So the ages 2 to 86, both acquired and developmental injuries or conditions. SC, they both said the same. They both had improved circulation. They both said it affected their spasticity and their stiffness. They had improved bowel and bladder, improved digestion, lower extremity edema. Both groups felt it improved their respiration. Spinal cord had decreased pain. The gentleman I talked to about when we started a standing program, when I first started with him, he had severe neck and shoulder pain. Remember, he's a C4. He hasn't got a whole lot going on up there. The pain was severe that it affected his sleep. It affected his ability to just be up during the day, and he could never really get comfortable. After having a standing program, he told me that his pain had significantly subsided and that he had better range in his neck because it wasn't so tight and he wasn't always splinting because of the pain. It prevents deformities. We've talked about it, that deformities are not caused by the spasticity. Deformities are caused by the spasticity maintaining the position and the person not being able to change that position so that the muscles shorten. When you're standing, you don't have any pressure on your ITs, or you shouldn't if you're upright. And you decrease the pressure and reduce your risk of pressure injury. So how do you do a standing program? How do you need to get it started? Well, first you start it as soon as possible. As soon as the people are stable enough to try. And when you start it, start slowly. Make sure you have a BP cuff, have those compression stockings and abdominal binders, and only go for a minute or 2. Start very slow and not all the way up. The body has not been up and upright. Our bodies can adapt to what we do to it, but we need to give them time. Once you've got them up to 30 minutes and they don't need constant monitoring in a therapeutic environment, you can take that standard and move it elsewhere. What would you do in standing? Could they be in speech therapy? I've talked with a speech therapist out of Texas. She likes to use standards because they have the increased expiratory volume. When she's working on feeding, you've got better alignment and better control of the swallow. When you're moving it out of the therapy, you also need to identify activities that can be done in the standard. Are there some that work and you can set up a workstation? Can they be doing active exercise or stretching? There's another webinar on our website that specifically deals in using the standard for stretching and exercise. Again, it's guided to its spinal cord, but the ideas and the benefits, you can adapt it to other diagnoses. Work on upper extremity activities. When you have the total body support, it's been demonstrated that you have increased upper extremity function, increased functional reach. So move it to OT. When you're working on certain things in therapy and you need 2 to 3 people to help this person maintain standing, use a stander. Take some of the supports out so that you can work on the trunk. You can move forward and back. But you also don't need to have the extra people because the stander is going to be giving you the support that you're having the other people do. I'm sorry. As I've said throughout, the experimental evidence is low, but the anecdotal and lived evidence is there. People who use their standards demonstrate and tell us that they are getting these benefits. We've also seen that when you stop using standards for various reasons, I mean, the quintessential study is done with people in schools. Their spasticity is reduced, their range of motions increased, and Christmas vacation comes and they go home. It happened to us all with COVID. We saw what happened to patients who weren't participating in therapeutic activities. We lost skill. The benefits of standing are time dependent, frequency dependent, and they only last as long as you continue to stand. So I hope you guys have enjoyed this. Does anybody have any questions? Are they in there? Yeah.
Yep, it looks like we've got questions in the Q&A, and then if you have questions for Marianne, put them in the Q&A or in the chat.
Linda, it's 30 minutes a day. They say 5 days a week. I've seen studies that are getting results 3 days a week. If somebody has severe tone and contractures, I would tend to go a little bit longer, maybe 45 minutes or 2 sessions of 30 minutes. But some is better than none. I know a lot of people who work in group homes, and they're very happy if they get up once a week. Yes, a patient with a hip subluxation can stand. You need to get it cleared by the orthopedist or the physician. One of the orthopedists at Children's Hospital says if there's not too much pain, if the patient can stand comfortably, it is worth having them up and stand. I've had people who have no hips, and the orthopedist has recommended standing. So it's all based on their pain level and how they're functioning, but do get it cleared by their orthopedist. Anybody else?
We can wait a few minutes for some more questions to come in if anybody has any questions. But I will kind of start to wrap things up here. I just want to thank everybody again for your attendance in today's webinar. The link to the course slides is in the chat. Everyone should be able to see that. Since there's nothing else in the chat right now, I'm not going to go ahead and post that again. It should be the first thing that shows up. Let's see. This is all available on Ultimate Medical's website, ultimatemedical.com/education. Obtaining your CEU certificate, your certificate of completion for this course should be easy. To receive your credit, you must complete the survey at the end of this course. The survey should automatically populate in your web browser when you click Exit Webinar. If the survey doesn't automatically populate, don't worry. The link will be available to you in a follow-up email you should receive from Zoom in approximately 24 hours. If you don't receive that follow-up email, please be sure to check your spam folder, but if you have any questions, don't hesitate to email us. This course will be on demand soon, along with Ultimate Medical's entire catalog of on-demand CEU accredited courses. If you or someone you know needs some more free CEUs available on your own time, be sure to check that out again at ultimatemedical.com/education. We have a podcast, Positioning 365 Beyond Seating. If you liked this, webinar, Marianne covers some really interesting topics with some great people and some super interesting discussions available on Spotify and Apple Podcasts. That's Positioning 365 Beyond Seating. Again, thank you for your time and attendance this afternoon for our webinar. We hope you've enjoyed it, and we hope to see you again soon. If you have any questions after the conclusion of the webinar, please don't hesitate Marianne or myself at education@ultimatemedical.com. Thank you.
So Deb, it's not the same recommendations for pediatrics. The timing is different. I should do this. 45 minutes minimum. If you want spasticity, it's usually 45 to 60. Email me and I can send you the thing. I'm not trusting my brain. For hip development and bone mineral density, it's 45 to 60. But what I've been hearing anecdotally for hip development is it's 120 minutes a day, 7 days a week. You want to try when you're doing any of your standing and you're looking at that chart on what the dosing is, it doesn't have to be 120 minutes all at once. You can break it up into different sessions over the day. I would not do a session longer, especially if you're working towards tone and range of motion, less than 30 minutes at a time, but you can have multiple 30-minute sessions. I hope that answers. And feel free to use my email and send me any questions you may have. And thank you guys for taking time out. I know on the East Coast it's getting dinner time. No problem.